Hello, everyone. Thanks for joining us for this Part B, Psychiatry, Common Rejections and Denials, a webinar designed for those who submit claims on the CMS 1500 claim form or the 837P professional electronic claim. My name is Mary Mulco. I'm a specialist on the Provider Outreach and Education team at WPS GHA. I will be your host today. Assisting me is my friend and colleague, Tom Ryan. We include this disclaimer in all our education, and we do so to remind learners that although we made every effort to provide current information that is correct, the information is indeed subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage, and these laws, regulations, and rulings will always prevail. We will provide responses to any questions based on the facts given. And just as a final reminder, CMS prohibits recording of this presentation in any form for profit-making purposes. Our agenda today is focused on psychiatry or Specialty 26, those claims submitted on the 1500 claim form or the 837P electronic form. During this webinar today, I will be discussing, just as I advertised, common rejections and denials for psychiatry claims, how to fix and avoid both, and I'll be providing resources throughout the presentation. And then I'll conclude with presentation-related questions and answers. I did receive quite a few advanced questions during the registration process, some of which are not related to the information that I'm going to be providing during this webinar and that I advertised I would be providing. But I did send out an email to all of the learners who registered to let you know where you can find answers to those questions that won't be included in today's presentation. Now, to fully understand rejections and denials, what we're talking about today, it is important for you to recognize the path that a claim takes, or what we like to call the life of a claim. This is a simplified graphic on how a claim actually gets into the Medicare claims processing system. Of course, the provider is going to render the service, submit the claim, and then the system will reject the claim if it's not in a content format that is required. When that happens, or when a claim comes into the system, there will be a 277 or 999 report available. I want to talk a little bit more about claim submission. Most providers submit claims electronically. Very few qualify for a waiver under a law that prohibits payment of services or supplies that a provider did not submit to Medicare electronically. Now, to confirm claim receipt, providers should use the 999 report and use the 277 report for more specific information. Our electronic data interchange, or EDI staff, provides helpful information. They do so in the Medicare 277 or 276, 277 companion guide. This is what's going to help clarify and further define the data content requirements for an electronic claim. Now, it is based on these reports that a provider or his or her staff will be able to know if the batch is rejected and if you need to correct or resubmit. This then is a graphic showing what happens to a claim that Medicare deems as unprocessable. Of course, the service is provided, the claim is submitted, but something's wrong. There's an incorrect format, something's illogical, or something is incomplete. And a remittance advice is generated to explain that that claim is unprocessable. This slide shows the difference between rejections versus denials, and they really are two different things. I think sometimes we all tend to use one of those words in place of the other, but really and truly for Medicare, these are really different things, and you need to recognize that. A rejection occurs when the claim is not processable. It's called unprocessable by CMS. It's returned on the front end. It's actually never adjudicated. The reason why the claim is rejected is because something's illogical. Something's missing or incorrect on that claim. For these claims, because they're never really adjudicated, there are no appeal rights. What you need to do is resubmit the service. Fix it and resubmit it. Now, there are codes that will appear on the remittance advice, which I'm going to talk about in just a moment, but an MA 130 remittance advice remark code will tell you that the claim contains incomplete or invalid information and that no appeal rights are afforded because that claim is unprocessable. There will also be a CO16 group code on the remittance advice, and what that means is that the patient is not liable for payment. Now, the denied claim, as opposed to a rejected claim, is indeed adjudicated. However, payment is not made or can't be made because it fails to meet payment criteria. This could be for a number of reasons. It could be due to statutory requirements, maybe medical necessity or frequency, and typically that's defined in a national or local coverage determination. Another reason a claim may deny is because of eligibility. Maybe the provider's not eligible on the date of service, but it could also be that the beneficiary was not eligible on the date of service. Now, for most denied claims, there are appeal rights available, and you will see that MA01 Remittance Advice Remark Code, and this is a remark code that tells you that if you do not agree with what we approve for these services, you may request an appeal. And that in order to make sure we're being fair, that appeal will be done by another individual that didn't process the initial claim. So the MA01 or the MA01, I should say, is what you will see on the remittance advice remark code. Or on the remittance advice. That means that the patient liability is to be determined. I want to talk next about processed claims, and this graphic shows the path for a processed claim, one that is indeed adjudicated. The provider renders the service and submits the claim. One of two things will happen. That claim will either pay or it will deny. Any remittance advice will be generated. I want to talk a little bit now about the remittance advice, or the importance of it. Sometimes we call the remittance advice the RA. Other people refer to this as the remittance notice. Some people even shorten it even further and call it the notice. Now, most providers do receive an electronic remittance advice, or ERA, as opposed to a standard paper remittance, or SPR. Depending on how the claim processed, it may include information about any adjustments made to the claim or denials. It could also include information about something that might be missing. Sometimes it will provide notice about refunds or even offsets. The electronic remittance advice provides payment information about the transfer of funds and payment processing from a health plan to a healthcare provider's bank, or the explanation of benefits, or what we call the remittance advice. Now, the CMS remittance advice booklet that CMS used to publish is no longer available. Instead, CMS now makes information about the remittance advice or the ERA available on their website. And I'll have Tom place a link to the healthcare payment and remittance advice webpage into the chat. So this information on the web page will provide for you information such as, kind of an overview of the remittance advice, the components of it, and how to read it, either the institutional remittance advice or the professional remittance advice. There are codes on the remittance advice that provide information about the claim. You can see them listed here on this slide. Claim adjustment reason codes. We call those CARCs. These explain why a claim paid differently than it was billed, and a remittance advice remark code, or what we call a RARC, provides more details about an adjustment that's described by a CARC. Let's talk a little bit about group codes next. Claim adjustment group codes. This is another type of code that appears on the remittance advice, and group codes convey the financial responsibility for the unpaid portion of the claim balance. A CO group code stands for contractual obligation, and this means that the provider is liable and cannot bill the patient. If a PR group code appears on the remittance advice, it means that the patient is financially responsible. You can find code lists, RARCs, PARCs, group codes, all of these, on the Washington Publishing Company website. This is a company that maintains those codes for CMS. Now, we do understand that some of the codes may be rather cryptic. Some of them may be even appear as though they're out of date, and I'll give you an example of that. Some of the codes, when they explain why the claim was rejected or denied, may use an acronym in them that is no longer used, and one example of that is HICN, HICN, Health Insurance Claim Number. We know that the Health Insurance Claim Number has been replaced by the Medicare Beneficiary Identifier, or the MBI, but those code descriptions have not been updated. Another example I can give you is that sometimes those codes maintained by Washington Publishing Company under contract for CMS contain a reference to an ICD-9 code. We're no longer using the ICD-9 code on Medicare claims. It is the ICD-10. We can't change this, as I mentioned. These are maintained by Washington Publishing Company, and if there is any change to those descriptors, it would have to be by that contracted provider. All right. There are potential actions that you need to choose from depending on whether your claim is rejected or denied. Very different, as I mentioned. After reviewing your RA, you're going to need to choose your action. So for an unprocessable claim, or one that we call rejected, you're going to need to fix the error and resubmit that claim to Medicare. If the claim or the claim line denied, there may be multiple actions to choose from. You may be able to simply resubmit the service. You might be able to use the clerical error reopening, or CER process, to fix those clerical errors, and CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. Now I'll talk a little bit more about the CER process, that clerical error reopening process, a little bit later on in this webinar. Another action that you can consider is an appeal. The remittance advice will provide appeal rights when those are available. I'll discuss appeals a little bit later on in this webinar also. Registered users can use our transactional portal to either render a clerical error reopening or request an appeal, and these self-service tools really do offer the most efficiencies. Our portal user manual, available on our website. I have a link to it a little bit later on in this presentation or in your materials. It provides illustrations and step-by-step directions to use both of these portal features, as well as the other various functionalities of our transactional portal. Now that I've described the difference between a rejection and a denial, I'm going to talk about whether you need to correct or appeal the MAC's decision to pay or deny a claim. I talked earlier, just a couple of minutes ago, about the clerical error reopening, or the CER process, and I told you that I'd share more details. This is a process to correct those human or mechanical errors, as CMS describes them. Clerical errors or minor errors are limited to errors in form and content And omissions do not include failure to bill for certain items or services, but examples of acceptable clerical error submissions are a mathematical or computational mistake. Maybe a code was transposed, either a procedure code or a diagnosis code. Perhaps there was inaccurate data entry that occurred, misapplication of a fee schedule, or some other type of computer error. These are examples of those types of errors or minor errors uh, that are those that can be rendered under the clerical error reopening process. But there are some examples also of situations that cannot be processed as a clerical error reopening. These are included in what I think is a great resource. It is the final bullet that you're looking at here on this particular screen. It's called How to Request a Clerical Error Reopening. That is a resource that's available on the WPS-GHA website. It lists those errors that are available to be rendered using this process, those that cannot be processed as a clerical error reopening. It also tells you how to submit your request. You can do that via telephone or fax, or you can use our transactional portal. And remember that the self-service option is always the quickest. You can also submit those clerical error reopenings, or you must rather submit them within 1 year of your remittance advice receipt date. So important to keep in mind, if you intend to render a clerical error reopening, whether you're going to do it self-service or request it via phone or fax, you need to do so within 1 year of your remittance advice date. I talked about the clerical error reopening process and how you can fix claims. Now I'm going to talk about appeals for just a bit. For claim denials, most often you can request an appeal. Not always, but most often. And remember, your remittance advice notice is going to give you those appeal rights. It's going to talk about those. The purpose of the appeals process is to ensure the correct adjudication of claims. So physicians, suppliers, and beneficiaries have the right to appeal claim determinations that are made by MACs. The beneficiary or their representative can request an appeal on any service that is processed for them, and providers and suppliers may appeal services for which they accepted assignment. For those unassigned claims, providers and suppliers can act as the beneficiary's representative, but the beneficiary needs to sign an authorization statement. In addition, providers and suppliers can request a redetermination on an unassigned claim if Medicare denies the service as not medically necessary, or if the provider or supplier billed in excess of the limiting charge. And if that's the case, the provider or supplier must also refund any fees collected from the beneficiary. The first level of appeal is the redetermination, and it is the only level of appeal that is rendered by the MAC. Time frames apply to each of the 5 levels of appeal. Additionally, there is a minimum amount in controversy. You might see the acronym AIC used. That stands for amount in controversy. A minimum amount in controversy applies to levels 3 and 5 of the Medicare appeals. You can combine like denials or similar denials on more than one claim in order to reach that amount in controversy. And you can see here on this slide, I've actually provided the name of level 3 appeal, the administrative law judge or ALJ hearing, and level 5 appeal, which is federal court review. There's a lot more I can tell you about appeals, but that's not our focus today. Our focus is the rejections, denials, how you can fix them or that you can appeal them. I'm going to give you the resources that you can find. But these listed here on this slide are absolutely terrific resources. The first is a resource that appears on the WPS-GHA website. The title of it is How to Appeal a Claim Determination. And remember, it is only the level 1 appeal called a redetermination that is performed at WPSGHA. Level 2 through level 5 are not performed by WPSGHA. The second resource here on this slide, and you can link to it when if you download the electronic version of these presentation materials, is a resource that's updated annually. It is CMS's Fee-for-Service Appeals Process Flowchart. And what I particularly like about this flowchart is it shows you the time frames for level 1, when you need to submit your request by. But it also tells you how long the level 1 appeals contractor, it would be the MAC that does the redetermination, how long the MAC has to render a decision. Similarly, level 2 is the reconsideration. This flowchart tells you how long you have to request a reconsideration after the redetermination notice is sent. And it also then tells you how long the qualified independent contractor has to render their decision. So full of really great information, time frames, dollar amounts for those amounts in controversy, and so on and so forth. So that's a great resource that I like to recommend to people. The next portion of today's presentation, the final portion of this webinar, focuses on the data. I used a tool that we call the, in short, data dashboard to pull the data that I plan to share with you today. The data dashboard is actually an interactive tool. It was designed by one of our data analysts in our Insight department. Insight is the name of the unit at WPSGHA that's responsible for mining data and data trends, among other tasks and responsibilities. So it's a great tool recently made available to provider outreach and education team members. So we can pull the data ourselves using that interactive tool rather than ordering the data from the Insight data unit or health and informatics unit. So I want to talk about the data itself. The data that I'm sharing today is all Specialty 26 or Psychiatry submitted claims. These are or include Jurisdiction 5 and Jurisdiction 8. So that means the states of Iowa, Kansas, Missouri, Nebraska, those are our J5 states, or Jurisdiction 5, J5 is short for that, and Indiana and Michigan, our Jurisdiction 8 states or J8 states. So all of these states collectively, 6 different states or 6 states altogether. So while the dashboard does allow us to drill down by a specific state or states and even counties, I pulled data for our entire jurisdiction, so all 6 states. For those of you that are wondering what Specialty 26 is, and I just mentioned that a couple of minutes ago, it is a code assigned to WPSGHA providers when they enroll. And during enrollment, providers self-designate a specialty. Physicians, anyway, self-designate. While a provider can designate a secondary specialty, it is only that primary specialty, the one that was self-designated, that is used during initial claim processing, so within our edit system. There are some situations where a provider will request an appeal. They will provide information to the MAC or the appeal contractor that they have a secondary specialty, and in some situations then based on that information about the secondary specialty, Medicare can make payment for something that was previously denied. So I pulled claims submission dates September 1, 2023 through December 1 of 2023. The data was last refreshed on December 12 of 2023. So any claims submitted for this date range, September 1 through December 1, or that were submitted after December 12, won't be included in my data. It's a 3-month snapshot. They refresh the data every now and then. I had to pull data a while back when I was putting these presentation materials together. Now, if I wanted to, I could go out today and pull submission dates that were even closer to today's date. But in order to get this in print and published and available for this webinar, I had to use these dates, September 1 through December 1. So here then are the top rejections, rejected claims. That means these are those unprocessable claims I talked about. These are claims that you have to fix and resubmit because they were never adjudicated. The remittance advice tells you that these claims were rejected, that you need to fix them and resubmit them. So these are the beginning of a list of common rejections based on the actual data I pulled for that snapshot period that I just talked about, September 1 through December 1, only for Specialty 26, only for those providers who during enrollment with WPS-GHA specified that they are a psychiatrist. So the number one reason why we rejected psychiatrist claims is that the claim should have been sent to the Health Maintenance Organization, or HMO. The claim should not have been submitted to WPS-GHA. This means that the beneficiary has chosen a Medicare Advantage plan. There were 2,251 rejections during that 3-month time period for all 6 of our states, Specialty 26. The second most common, or another common, I should say, rejection is that it says denied, and here again is one of those rather strange explanations, or the verbiage used really isn't correct because it wasn't denied, it was rejected. So it says denied field 11 of the HCFA 1500. There again is an outdated acronym, but still being used in these explanations that you receive on the remittance advice. Field 11 of HCFA 1500 must be completed, and this is the field on the CMS 1500 claim form, or the electronic equivalent, that states whether the patient may have other insurance that is primary to Medicare. Another common rejection error is that the claim lacks information needed for adjudication. This is one of those reasons that you're going to need to dig a little deeper with. Sometimes more than one reason code is placed on a claim. For those of you that are registered users of our portal, there may be additional information there. 646 claims denied there I said a bad word, it's rejected. The claim rejected because the claim lacks information needed for adjudication. The next one is very, very similar to the top reason for rejection, 383 claims in that 3-month period. This is a little cryptic too, but the long and the short of it is this reason, and you can read it there in that 4th bullet, means that it's a misdirected claim. These are for services, once again, for HMO members, someone who has elected a Medicare Advantage plan versus traditional or original Medicare. WPS-GHA is a MAC, Medicare Administrative Contractor. We process Part A and Part B claims for traditional Medicare or original Medicare. If you submit a claim to us for a beneficiary who is elected Medicare Advantage, you need to go to the plan with any of your questions or concerns about rejected claims or denied claims, or why they're not following the fee schedule, or whatever question you have. If that patient has elected a Medicare Advantage plan, WPS-GHA cannot assist. You need to go to the plan. Next on the list is place of service comes with proceed code. Within the claims processing system, there may be edits built to show that this CPT code or this HCPCS code is only valid in certain places of service, or only covered rather in certain places of service. So that happened 247 times, and you can see that this this error message actually says or tells you submit a new claim. More rejections on the next page. The claim must be submitted to Railroad Board Medicare. This is similar to a beneficiary who has chosen Medicare Advantage, but the Railroad Board coverage is for those beneficiaries who work for the railroad. So their Medicare coverage or their Medicare claims are administered by the Railroad Board Medicare contractor, not by WPS-GHA. So 201 rejections. The next one is Patient, insured, HICN, and name do not match. There again is a good example of an outdated acronym being used. I guess the acronym is still good. We just don't use the health insurance claim number anymore in claim processing. But what this means is that the Medicare beneficiary identifier and the patient's name do not match. You need to submit a claim using the name just as it was spelled on that patient's Medicare card or the beneficiary's Medicare card. The next one, denied. Again, these are rejections, but there's just kind of some wonky language used. I'm not going to dispute that. This is a rejection due to an invalid or missing modifier. We have modifier fact sheets available on our website that tell you use this modifier for these situations. Don't use this modifier for these situations. Some of them even tell you the types of CPT codes or HCPCS codes that they're applicable for. So some really great information, and I'll show you where those modifier fact sheets are in just a little bit when I go out to the website and do a little demonstrating for you. Missing, invalid, or incomplete ordering provider identifier, 50 claims, rejected. You'll need to fix that ordering provider or primary identifier on the claim. There are claim form instructions that tell you where to put what on a claim form. I'll be talking about that a little bit more when I get into the demonstration portion of this presentation. Lastly, I pulled about 10 of the most common rejections and about 10 most common denials to share with you today, because you can see there's quite a difference between the number of these rejecting within that 3-month period. You know, our top rejection was 2,251 of claims that should have been sent to the Medicare Advantage plan. But here we're down to 40 already. So I stopped listing those rejections by reasons when I got to 10. And that one, this one says invalid, again, using verbiage denied, it was actually rejected. Invalid, incorrect ICD-9 code, and there again, we're using ICD-10 codes now. Resubmit as a new claim. So that takes care of the identification of rejected claims. That tool that I talked about, that interactive tool that I use to pull this data, can also identify for us the top rejections and denials, not only by the code that's used, but by HCPCS code. And I thought it would be interesting to show the top rejections by HCPCS code here. The 99232, that's a level 2 subsequent inpatient hospital care code. 99214 and 213, also 99215 and 99212 here are office services that were denied within that 3-month time period. More levels of inpatient visits there shown by the 99233, 99231. 90792 is a diagnostic psychiatric evaluation with medical service. That was one of the top rejected claims for specialty 26 providers in our jurisdiction. Could be due to frequency, because the policy for that, for psychiatry and psychology services, and I'll show you where to find that in just a bit, actually states that we allow 1 per 6 months unless there are certain situations that are documented in the medical record. So that is likely frequency. Or perhaps it was a case where someone or a provider type, no, it couldn't be, because I pulled these by specialty 26. And a specialty 26 provider is indeed eligible to bill these services. So there may be some of these services that are being denied when there are provider types that are submitting this with medical service code that aren't eligible to bill that. But I don't want to mix up rejections with denials, so I'm going to stick with it, saying that this is likely due to a frequency. 96372, another top rejection by HCPCS code or CPT code, and this is an injection under skin or muscle. I'm not sure why this rejected, but I can tell you that it may be a situation where we're not paying for the drug, so we're not going to pay for the administration. You know, I would need to look at the codes on that remittance invoice to tell you for certain why 96372 rejected. And then, of course, the 90833 is a therapy code, a psychotherapy code. And then the others, the last two, are more office visits. So we talked about, or I talked about, rejections by reason. I talked about rejections by codes. Now let's take a look at those top denials by reason code. Look at number one, folks. 1,612 claims came in to WPS, were processed, denied, because it's a duplicate charge that was already paid on a previous claim. Think about how much money it costs providers to submit those 1,612 claims and for Medicare to adjudicate those claims because they are indeed a denial. We recommend that you don't just set up something within your system to send a new claim within every 30 days. For example, if you're using a billing service that does that, tell them to stop doing that or ask them to stop doing it. You know, pay attention to the information on those remittance and don't just automatically resubmit on a, you know, like a monthly basis. It's not recommended. Look at the next one. The time limit for filing your claim has expired. 1,010 claims denied. Psychiatrist claims in our 6 states in that 3-month period because the time limit for filing the claim has expired. 940 claims denied because expenses incurred after coverage terminated. The next one, or the next two actually, on the top denials by reason are those that pertain to our Medicare secondary payer program. The claim must be sent first to the EGHP, which is the employer group health plan, or the large group health plan first before Medicare can consider payment. And there was no evidence that was done or sent with the claim, so those were denied. Next one is claim previously paid or may be paid under an employee group health plan through disability, 797 denials. So what we're looking at there is a situation where there is something in the eligibility files for that beneficiary showing there's disability. And so we're looking for that information that should have been paid under the EGHP before coming into Medicare for payment. More top denials for Specialty 26 only. Charges incurred during an incarcerated period, 639 denials. Payment included in another service received on the same day, also 639. That would be a situation where you would want to look at the National Correct Coding Initiative edits to see if both of those services that are being billed by the same provider on the same day for the same patient during the same encounter can be billed. These were denied, but perhaps they could be covered. You would need to look into that, and you would verify that by looking at the National Correct Coding Initiative edits on the CMS website to see if those procedure to procedure code edits show you an indicator that means you can append a modifier to make payment for both services. I'll talk more about NCCI in just a minute. Medicare does not pay for this many services in this time period, 578. That's a frequency denial, which means medical necessity. Every time something denies due to frequency, you're talking medical necessity. You should consider presenting your patient with an advance notice of advanced beneficiary notice of non-coverage for this type of denial, because it really truly, whoops, I went too fast here. Sorry, folks. It means that it's a medical necessity denial. Again, here, similar to the number one reason for denials for psychiatrist claims at WPS GHA is duplicate charge. 572 more. There's different types of duplicate denials that can occur. We actually have a website article that speaks to the different types of duplicate charges and how to avoid them. Lastly, Medicare will not pay for this service for this condition. When you see something like this, again, it's a medical necessity denial. And typically that would mean that there's either a national or a local coverage determination that determines payment. Okay. Top denials by HCPCS code are listed here. Again, we have these subsequent inpatient visits, office visits, those psychiatric diagnostic evaluations with medical services, um, pretty much the same categories that were rejected are being denied. There is one code a little bit different here though, 96127. We had 452 denials. That's a behavioral assisted children or adolescent code. So perhaps that would be a reason to look into if the service was actually being submitted for the correct patient, for the beneficiary, or if another code would be more appropriate, because that is a code for children or adolescents. Couple more there, injection and more therapy. So I have a some of these or a lot of these are E&M codes, both on the rejection list and on the denials list. For those of you that are seeking advice on evaluation and management services or codes, I highly recommend checking out our E&M playlist on the WPS-GHA YouTube channel. And I've asked Tom to place a link to the E&M services playlist in the chat. Okay, you've seen an example now of that, what I can find in that interactive list or interactive tool to pull information about rejections and denials. Here it just shows you the slide I've included to show you that we can further break down that data. We can break it down into county, state by reason, state by code. We can also look at trending. So here's the kind of things we can view or review when we're looking at trending. And I have to tell you, when I click that button to pull that data, it is a matter of seconds that this data comes back to me. It's just amazing. But here's a list of details that we can see when we use the dashboard to view trending. And I'll show you an example of that right now. This is the example. The code is an internal code we use to pull that's assigned to the reason for that denial. This is an F87. That means charges incurred during an incarcerated period. We can see a claim count the last 3 months was 639. Claim count for 3 months prior was 517 for that F87, the reason code. The difference in number of claims is 122, and this dashboard tells you all of this information that I'm telling you now. The claim percentage change was 24%, and then there's an arrow that appears up, meaning it was an increase or down. So we can pull this data from this dashboard and see quickly trending for denials or rejections. What did we see? What are we seeing this 3 months? What did we see the prior 3 months? Did it go up or down? So this kind of helps explain to us where we need to focus our education. So I mentioned to you some of the tools that I was going to show you or talk about a little bit later on. That's this portion of the webinar. There are requirements for submission of Medicare claims, specifically in the Medicare Claims Processing Manual. It's Chapter 26. This is where it tells you item by item on the claim form what has to be present on the claim. That's in Chapter 26. It speaks to a paper claim. It goes item by item. Item 1 on the claim is this. Item number 2 is this. Item number 3 is this. And this is what you need to place there. Good descriptions are included in that Chapter 26. However, we all know that most providers now submit electronically. So it is the crosswalk that you need to look at in order to find where you put it on that electronic transaction. And I want to show you real quick, just pull this over. This is our EDI page, and I've actually provided a link, in your presentation materials to that. But if you go to the WPS GHA website and choose EDI from the quick links, you will be able to go to this page and you can choose Medicare EDI and this crosswalk. When you open this crosswalk, I am going to open it because it's a great tool. This shows you, I'm going to make it small, a little bigger here for you. Sorry about that. All right, so I'm going to just kind of blow this up for a minute to show you that this crosswalk shows that if item number 1 of a claim is where you put the type of health insurance, this is where it goes then, and the data elements and requirements for the HIPAA compliant version 5010 claim. Item number 2 on the claim is the patient's name, and this is where you need to put the information on the electronic claim. Of particular help is this status column here, and R means that that information, that data element is required. That's right down here. And S means it's situational. So depending on if other conditions exist, you may or may not need to place that information on the claim form. One of the top denials or rejections, one or the other, I can't remember specifically, was that the information in item 11 was missing. So you can come here and look at what that information is that they're asking for, or CMS is asking for. All right, let's keep moving on here. This is that website resource I mentioned, how to correct a rejected claim. When you look at that resource on the WPS's website, or on the WPS website, you will see that we list remarks code for rejected claims. Those remarks codes that I talked about earlier. By the different remarks codes, you will know what you need to do to correct and resubmit that claim. So that's another great resource. Common claim denials is another great website resource, and these are kind of lumped into categories. So if you look at this resource on our website, you're going to see for rejections due to bundling, this is what you need to do in order for Medicare to make payment. Duplicate claims are listed there too. I'm going to show you that right now. Pull that over here. I'm going to see the name of that was common claim denials. I'm a searcher, not a navigator, folks, so I like to use search. And you can see it actually populates itself. Common claim denials, and there are the categories, those lumped categories. Duplicate claim service denials. Here are those codes that appear on the claim, and this is what you need to do to fix, or to, to avoid is what I should say, because you don't fix the denial, you're going to appeal it, but you're going to want to avoid that in the future. So this tells you some information about those entitlement denials. Again, a very common denial is the provider's not entitled or the beneficiary's not entitled. Payer contractor, this is those cases where you submit to Medicare Advantage, or you need to submit to Railroad, United Mine Workers, and so on and so forth. So a couple of those were our top heavy hitters. There's another heavy hitter, it didn't show for Specialty 26 for psychiatrists, but this is another big hit. Another big reason for common claims denied in Medicare is that the patient is enrolled in a hospice. And then, of course, there's information here that pertains to those provider number denials, and that was on the list of top or common denials for psychiatry claims. All right, moving back, I'll move this off. Modifiers webpage. I should have told you that I would show you that information. That is available. You have the link to it in your presentation materials. But there, I'm a searcher, and there then are the modifiers, and all of those fact sheets are listed here that I told you about. So great help, great assistance. Let's take a look at one real quick. Tells you appropriate use, inappropriate use, the documentation you need, even more information. You know, it depends, of course, on that particular modifier. But these are very helpful, and some providers don't know that they exist. So great information. This is where you're going to find help for those incarcerated beneficiaries, modifiers you need to use, and so on and so forth. If you're using an advanced beneficiary notice of non-coverage, you'll find modifier fact sheets that speak to the modifiers that need to be considered to append to a CPT or HCPCS code in order for Medicare to make payment. Website resources here is where you can find those National Correct Coding Initiative edits. It's a web page. I know that I recently held a webinar about medically unlikely edits, so that's a recording that's available out in the WPSGHA on the YouTube channel. But specifically what you're going to need to look at here because of Specialty 26 denials are the procedure to procedure edits. And those are those edits that occur or that happen when two E&M services or two services are billed on the same day by the same provider for the same patient during the same encounter. One of the questions that was asked on the rejections, or not the rejections, on the registration, someone wanted to know how can we get the E&M service to pay on the same day as a consultation service. You'd need to check these procedure to procedure edits to see if those CPT codes are both there. You need to check the modifier indicator column to see if it's appropriate to append a modifier to the column 2 code in order to unbundle payment. Now, don't just append that modifier if it tells you you can. You need to first look in your documentation to see that it is indeed appropriate to append that modifier. And because of one of the top denials for psychiatry claims was those that dealt for those incarcerated beneficiaries, I've included a resource here for you that appears on our website that will tell you about billing for incarcerated beneficiaries or when Medicare can or cannot make payment. The IVR is a self-service tool to use 24 hours a day, 7 days a week, with limited functionality outside our normal business hours. You can use this to check eligibility, claim status, details. You can use your voice or telephone keypad, and we do have an operating guide available to help you use this system. You can check your claim status and details in the WPSGHA transactional portal. You need to register to be a user. Of course, you need to log in order to check eligibility or claim status, details, and claim actions. And this is where I was telling you that if you use this self-service tool or transactional portal, or the portal as we call it, you can actually look at claim details or claim line details. There's a button that appears. It has more info on that button. You can see that in the third bullet here. If you click on that button, it will give you more claim details as to why that claim line may have denied or denied. So this is a great way to find additional information out about why your claim line denied. When you use that more info button, if there is a situation where your claim may have denied due to the fact that it was a condition we don't pay for this service, it very likely will also link you right there to the policy that is in effect, or the policy that helped us make that determination. So it's a great tool to use. If you don't know how to use it, there is a portal user manual. I've included a link to it here. The portal user manual also, there's a tab that appears at the top of each page on our website. It's right here. That gets you to that portal user manual. There's illustrations as you select each of these functions. There's illustrations, there's step-by-step processes identified. So it's a great, great tool. All right. I just want to remind you of those self-service tools. They really are the fastest way to take corrective action when you have a claim that we've processed. One other tool I want to show you quickly is something I mentioned earlier. If your claim denies because it's not a condition that's payable, it's very, very likely that it's based on a policy. So I want to show you how you can find policies. This is the WPSGHA website homepage. If you're out on any other page of our website, this is our training website. Well, you can jump to those encore presentations I talked about earlier. But if you want to go back to the homepage, just click on this logo. There's a code lookup tool on our homepage that you can use to look to see if a particular service or CPT code, HCPCS code, or even ICD-10 code is included within like the LCD or NCD, so that allows you to do a quick search. And sure enough, that 90792 that appeared on our common denials is right here in the Psychiatry and Psychology Services policy, and in the billing and coding article for that same policy. So just another great tool that WPS offers. Mention to you also the our YouTube channel. There are tons of, or there are very many, there's several of recordings of previously held websites. I just finished up a series on mental health. There were 6 webinars recorded, one on telehealth, one on incident 2, one that talked about the policy, one that talked about, you know, who's eligible to bill. You know, just some really great resources for you. Look for the playlist on the WPS GHA YouTube channel. All right, we have just a few minutes left for questions. Tom, have we received any questions?
We do have 2 questions. So the first one is how to find or determine what information is needed for claim lacks information for adjudication to resubmit the claim.
That's a great question, and it's one of those rather cryptic messages that I talked about. For that one, I would recommend registering and using the portal. That is going to give you the very best information. Let me just step back here a couple of slides. I'm going to go quickly because we don't have a lot of time left. And I didn't find it quickly enough. Use the portal and use that more info button that's available for that claim line in order to view additional information about that particular denial. Maybe I'll find it here. That would be my recommendation. That's the best way. And the other question, Tom? There it is.
All right.
This is that more info button I talked about. Sorry, Tom.
Can you show us the incarcerated beneficiary modifiers?
Sure. I'm going to go modifiers. Remember, I'm the searcher, not a navigator. But first I have to spell it right, correct? Well, there we go. Modifiers. We have information on pricing modifiers and informational. As I move down, right here. Medicare beneficiaries in state or local custody is the name of that particular resource. And again, I just went to the modifiers page, scroll down for incarcerated beneficiary, and here is the article that provides information about modifier usage and when Medicare can and cannot pay for a beneficiary who is in state or local custody. I believe that one of my counterparts just held or is going to hold a webinar on this topic. So you have been a terrific audience. Our greatest compliment is when you recommend our education to others. Please consider doing so to help us reach the greater provider community and reach our goal to assure current and effective education for all of those people in our jurisdiction, providers and their staff, anyone. On behalf of myself and Tom and Provider Outreach and Education, I want to thank you for your participation. We look forward to your survey comments, and we hope to have you join us for future events. You may now disconnect.